Good morning. We're going to give everyone a few minutes to join us. If you are just now looping in, good morning, welcome. You are in the right place. If it's your first time with us, your camera is turned off, your microphone's muted. We just do that so everyone can stay focused when we get started here in just a couple minutes. If you have any coworkers or last minute friends that should be here, email them now. Okay, good morning again. I know there's still people trickling in. I'm just going to slowly get us started here. We have a lot of great content today. My name is Callie. I am Director of Marketing with Promises, and I'm here with Dr. Gwen Swift today, who's our Corporate Director of Family Services. Today we'll be talking about intentional use of internal family systems, also known as IFS, for trauma-informed care in behavioral health. Gwen, if you want to go to the next slide. Good to see so many familiar names on here. Okay, so Promises is a network of treatment centers. We have facilities across the country. Our two newest facilities, we spoke about Dallas last month. And this month, I'm excited to introduce our Promises Atlanta facilities. So we are growing. We do trauma-informed care. We have a sexual recovery program in Tennessee. We have mental health programs, addiction programs. Everything we do is evidence-based and outcomes focused. As you can see with all of these great clinicians that come in every month, everyone works with Promises. We're all really passionate about continuing to educate ourselves as well as our community so that we can all strengthen our treatment centers together. So, and care for our clients. You can go to the next slide. So yes, I'm excited to share that we just started accepting referrals this week to Promises Atlanta. And it's a mental health treatment center with substance abuse and co-occurring disorders. So if you have any interest or in that Atlanta area, I'd like to learn more, I'm happy to drop an email and some information about that. You can go to promisesatlanta.com to see a little bit more about us there. If you're not following us on social media, you can find us on LinkedIn and Facebook, and we're always sharing our updates there. We also share when we have new webinars that are being posted about. So if you have not followed us on Facebook and LinkedIn, you can find out more there. Go to the next slide. Okay, so I know many of you are here for CEs today. So this training is going to be accredited for 2 CE hours through NADAC and NVCC. You have to be here for the full training, so you cannot miss more than 10 minutes of the training. If you are here now, you are off to a great start. Just be sure that you're only using one device per person. So if you're sitting there with your coworker on one computer, only one of you is going to get credit. So make sure if you're on your phone, laptop, iPad, it doesn't matter. Just make sure you stay with us the whole time. You can also change devices. So if you need to switch from your computer to your phone, that is absolutely fine. After the training, you'll go to the same place that you joined today. So you got an email that said, join us now for the webinar. You'll get another email after this that says, go to that same place to see your survey. And from there, you can fill out your evaluation, and then you'll automatically see that a certificate of completion is there for you from CEGO. You have 1 week to fill out this evaluation, so make sure you do that before next Friday. You'll see a reminder email next week, and you'll get another email again after the webinar today. The account is free also, so you don't have to sign up for anything. I don't even think you actually have to have an account to create to fill out the survey, but if you do, you'll notice that within that account, you can see your past trainings, your past certificates, and all that in one place. So it is very helpful. Oh, and then I will also include our resource materials from today, and the slides will be in that attendee dashboard next week. So that will all be in the same place for you. Okay, go to the next slide. During the webinar, you'll see a chat box and a Q&A. The chat box is for me. If you have any questions about technology, our CEs, the webinar functions, if you just have a comment to make to me about the trainings, you can reach me there. Gwen will be monitoring the Q&A. So if you have any questions regarding the content or directly for her, we do have a Q&A section. So please send your questions to Gwen in the Q&A so we can keep those things separated. And that's it, I think. Oh, I do have 2 more slides. Go ahead. Okay, very importantly, about Gwen. She is our Corporate Director of Family Services here at Promises. She's a licensed marriage and family therapist and holds a doctorate of couple and family therapy from Drexel University. She is also an adjunct professor there and has taught the Person of the Therapist training program for students in the Master's in Couple and Family Therapy program. She's passionate truly about a systematic approach to treatment and recovery, education about trauma and the brain, and connection within our relationships. So if you've had a training with Gwen before, we're happy to have you back. I know this is going to be very informational and accessible. So you can get started. I think I have one more slide, Gwen, sorry. And I'll shut up. Okay, next month we have Fourth Friday again, April 25th, the Gut Brain Connection with Michael Fanjoy. And this is going to be understanding mental health from the inside out, which is very topical, I think. I will link the registration here when I'm finished. And I'll also give you a sneak peek into May if you haven't already signed up with Trish. If you were here in January, she spoke on ADHD and adolescence, and this is kind of a follow-up to that training a little bit, going deeper dive into that topic. And if you did not see that training, that is a-okay. She will do a recap there, and I'm also going to link, you can find the recording of that January session with her in our portal. So if you'd like to rewatch that before May, that might be a good idea. Okay, thank you all.
All right, good morning. And thank you, Callie, for your introduction. I'm going to move my face over here so I don't see myself. So again, my name is Gwen Swift. I am really excited to be here today to talk about trauma-informed care. And I am trained as a marriage and family therapist, as you saw in my bio, which means I am 1000% of the time working from a systemic lens. And we're going to talk a little bit more about what that actually means. So first, let me just review some of these training objectives and also let you know that we are going out of order today. So when you walk through these and you think about what we're going to be talking about, it's going to look a little bit different. But we are going to talk about the distinction between trauma-informed care and trauma resolution therapy, and recognize their distinct roles in different levels of care and in different settings in behavioral health. We will talk about the core principles of internal family systems, which I will mostly refer to as IFS, and how they align with trauma-informed care practices. And then we will talk a bit about how IFS principles can be applied to trauma-informed approaches in order to support our clients in a kind, compassionate, clear way. And that's what we're gonna do. So first, before I jump into any content here, so I have this beautiful chat box in front of me, and I always really like having some engagement when I am attending trainings. So I wanna first start by asking everybody to just put in the chat box, what does trauma-informed care mean to you? Right, so just think about different trainings that you have been to, the way that trauma-informed care makes sense in your own brain, how you understand it, where you first learned about it, whatever it is that you understand or don't understand about trauma-informed care. Let's get some sort of generative about that right now. So already I see a couple of people saying empathetic, unconditional positive regard for the client in all aspects. We're going to talk about client-centered care, establishing safety. I see a lot of safety, love that. helps to process trauma. We'll talk about that. What happened to you rather than what is wrong. Love that. It's very Gabor Mate. Sensitive awareness of how trauma presents in my clients, putting the client's safety first, a mindset, not a modality. Ooh, that's good. That is good. Compassionate listening, safe and trusting environment, choice and allowing autonomy, holistic treatment. These are beautiful answers, right? So a very important part of trauma-informed care, and I want to be sure to say this before we jump into the content for today, is understanding what actually is trauma, right? And a really helpful way of understanding that is by understanding what happens in the brain, what happens in someone's nervous system, what happens in someone's entire being when they experience trauma, right? And those are not pieces of our webinar today. And I just want to say that having this conversation, having this webinar is not a replacement for understanding the nuances and the mechanics of trauma itself, right? And I'm going to post some resources that give more information about how to learn about that, right? One being a previous PBHU webinar done by my wonderful mentor, Trish. So now that we have got a little bit of thought going about trauma-informed care, I want to start by giving some definitions because I come to a lot of trainings and I'm like, I don't really know what she's talking about, or I have to Google what different things mean. And so I just want to put out some different definitions so that we're all on the same page here. So let's start out with systems, right? You might have heard a systems approach to treatment or a systemic therapist or a systemic understanding of treatment, things like that. But let's break it down to what actually is a system, right? So a system is any entity whose parts relate to one another, right? So all biological organisms are systems. And human systems can include anything from one individual to a whole nation of people, right? So systems thinking was really introduced into behavioral health through family therapy, right? And our focus is the system at all different levels, right? So systems thinking is very holistic and it's comes with an understanding that there is a larger context in which we as human beings and groups and cultures are operating, and that we are impacted by that context. Next is SAMHSA, which is the Substance Abuse and Mental Health Services Administration. So this is an agency that was established by Congress in 1992 within the Department of Health and Human Services. And SAMHSA states on its website that it leads public health efforts to advance the behavioral health of the nation. So this organization does a number of different things, including providing leadership, supporting programs and services, delegating resource to help the United States act on the knowledge that behavioral health is essential to health, prevention, treatment, and all of the ways that we operate as human beings here. So if you're interested in learning more about what SAMHSA actually does, I would really encourage you to visit their website. There's a lot of information on there. And SAMHSA, I'm going to use SAMHSA's definition of trauma as well as a secondary one. So SAMHSA defines trauma as the result from an event, series of events, or set of circumstances that experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting adverse effects on the individual's functioning and mental, physical, social, emotional, or spiritual well-being. Now, some of you may be familiar with Gabor Mate. He is an expert in the field of addiction, stress, trauma, and childhood development, and I really appreciate his definition of trauma as well. So I'm going to give that here. He says, trauma is an invisible force that shapes our lives. It shapes the way we live, the way we love, and the way that we make sense of the world. It is the root of our deepest wounds. So I appreciate this definition as an additive for conceptualizing trauma-informed care, because I think it really captures the spirit of what we mean when we say a trauma-informed approach to treatment and care, right? So let me give now a definition of trauma-informed care from SAMHSA. It is a program, organization, or system that is trauma-informed, realizes the widespread impact of trauma, and understands potential paths for recovery, recognizes the signs and symptoms of trauma in clients, families, staff, and others involved within the system, and responds by fully integrating knowledge about trauma into policies, procedures, and practices, and seeks to actively resist re-traumatization. So something that we're going to talk about more comprehensively is the fact that trauma-informed care is distinctly different and importantly different from trauma-specific services, right? Or I will call it throughout this presentation, trauma resolution therapy, right? Because trauma resolution therapy is a specialized approach to therapy that helps our clients to process and heal from trauma, right? And in this, we are often looking to help our clients, like I always call it, like reintegrate different material that was not able to land properly in someone's brain, body, and internal system, right? Restoring a sense of safety, control, and well-being. Which brings us to internal family systems. So IFS is often used as a trauma resolution modality, supporting individuals, couples, and families, healing by accessing and healing the parts of them that have been wounded by way of traumatic experiences. However, IFS is much more than a psychotherapy approach, right? It is also an incredible tool to really understand humans as complex, strong individuals and beings that contain multitudes, right? Which is a part of trauma-informed care. So today, as you likely read in the description of this training, today is not a training on how to do internal family systems therapy with your clients looking to heal from trauma, right? Today is about how we can use this incredible tool to ensure that we as healthcare professionals, right, that we can operate with compassion, kindness, sturdiness, and humility to be able to lay our heads down at night and know that we have acted with integrity, right? So for those of you who might be interested in learning about how to use IFS as a psychotherapy, trauma resolution therapy, there is to be totally honest with you all, there is a very expensive and hard to get into training program through the IFS Institute. Though through PESI, there is a much more affordable and self-paced training that is also widely available and very valuable, right? So let me get into trauma-informed care. So again, I'm going a little bit out of order from my objectives, but we are starting with trauma-informed care. We're going to go into IFS, we're going to take a break, and then we're going to talk about the integration of the two, right? So as so many people noted very eloquently in our chat box, I'm gonna read you some more of these. Let me get through some of these. Mindful of a client's lived experience, being compassionate and understanding, understanding that trauma rewires the brain, safety, empathy, educating clients on what trauma is, how to create a safe place for when they are ready to talk about what's happening. That's a good one, right? Trauma-informed care is a lot of different things, right? And it's not just about the principles and the interventions. I love how someone said it's also about a mentality, right? Because you can have the most trauma-informed policies, the most trauma-informed organization, right? But if the people who are actually delivering the services are struggling to be trauma-informed in how they provide care, then none of those policies are going to be effective, right? So today we are focusing on the individual experience of trauma-informed care for us as providers and the interpersonal, right? And to help kind of frame this, I really appreciate using Bronfenbrenner's ecological systems theory, right? So this is essentially what this little like nesting doll looks like, right? It's a framework that helps explain how different environmental systems influence human development, but it just shows a really helpful visual that development and life exist within a complex systems of relationships, right? So if you are looking for guidance around trauma-informed care at different levels of the system, because today we're just going to be talking about individual and interpersonal, we also have prior trainings that talk about organizational trauma-informed care, and those will be listed in the resources that everyone will be able to have access to after this training, right? So when I say individual, I mean your internal narrative, beliefs about clients, being able to manage personal feelings and biases, which we all have, right? Interpersonally, it is your treatment team, it is your conversations with your colleagues, case consultation, supervision, coming home at the end of the day and debriefing about your workday with family or friends, right? All of these different places in our lives are different areas where we have opportunities to shape the way that we think and we feel and we act in our work. So again, we have very valuable, and I'm not just making a plug for these because I love my coworkers, right? But we have very valuable prior PBHU webinars that talk about trauma-informed care at different levels of the system. And Callie is going to link all of those for you because they all live on YouTube, right? One being Milieu Matters, right? So trauma-informed care from a community and from a milieu perspective, right? The importance of trauma-informed care. So this is a little bit of the mechanics behind trauma, a little bit more of a comprehensive understanding of what trauma-informed care looks like as a whole. And then co-regulation and trauma-informed care with families, right? So, you know me as a family therapist, it's not just about our clients, it's about the world that they live in as well. And it is just as important to be trauma-informed with our clients' families and the experience of their communities, their neighborhoods, their areas of the country that they live in, as it is to be trauma-informed with the client themselves, right? So first, let me talk through a bit of a history of trauma-informed care, right? So this is not a complete history. Let me just say that, right? This is, for the sake of time, a pretty brief history of trauma-informed care, right? And of course, there is much more to explore here. But the concept of trauma goes back obviously farther than 1998. However, I want to start with the ACEs study, the Adverse Childhood Experiences study. And if you aren't familiar, please become familiar. And we have resources that I will link that will help you familiarize yourself with this study, right? So this was a study that really looked at the impact of trauma on mental and physical health. This was a groundbreaking study that informs a lot of policies and practices that we use today. It was done by the CDC and Kaiser Permanente and existed in the 90s, exploring the relationship between childhood trauma and later life outcomes, especially in relation to health and well-being, right? So again, partnership between the CDC, Kaiser Permanente, and this is actually one of the most influential pieces of research in the field of public health, psychology, and social science. So it's incredibly important. It involved over 17,000 adult participants who were asked about their experiences of abuse, neglect, and family dysfunction during childhood. And again, I won't get into the specifics, but I encourage you to take some time to explore this. And one of the most significant findings was that a person's ACE score increased. As a person's ACE score increased, so did the likelihood of experiencing a range of negative outcomes in adulthood, right? Including but not limited to chronic diseases such as diabetes and cancer, mental health issues such as depression. You're going to see my cat jumping on my lap here. His name is Howie. And mental health issues such as depression, PTSD, behavioral challenges such as substance abuse, right, violence. Now, why is this so important? Why do I keep talking about the importance of understanding the ACEs study? Right? Because it helps us to understand the behavior of our clients better and, to be quite frank, have less judgment around them, right? Be able to better manage our own personal feelings about the behaviors that we witness in our clients, right? And this study has greatly influenced the call for trauma-informed care, right? Simply because of how prevalent ACEs are in human beings around us. So we come to the early 2000s where SAMHSA begins to integrate trauma research into behavioral health policies, right? Recognizing that trauma really significantly impacts mental health, substance use, overall physical health, right? And SAMHSA begins to formally define trauma-informed care principles, right? Emphasizing the need for being able to really recognize trauma's impact on different systems. Now, from 2010 to about 2014, SAMHSA develops a comprehensive framework for trauma-informed care, right? And we're going to talk about two of the different frameworks that SAMHSA has presented about this, right? Which one of them is called the 4 Rs. In 2014, SAMHSA's efforts over the last decade really culminate in the publication of the TIP 57, which means Treatment Improvement Protocol, right? So this was a major milestone in really officially recognizing and integrating trauma-informed principles in behavioral health. And again, I have a whole bunch of this stuff linked at the end of this presentation that everyone will have access to, right? So this provided clear guidance for providers and organizations on how to utilize trauma-informed principles, which brings us to today. Right, we are seeing a growing awareness around how trauma is understood, particularly in relation to marginalized and oppressed communities. Right, historically, trauma-informed care focused mostly on an individual experience of trauma, right, such as abuse or neglect. However, the field is coming more and more to accept and grow regarding social determinants of health, systemic oppression, and collective trauma as a very real experience that we need to pay attention to, right? So this means that trauma-informed care is broadening its scope and recognizing how communities, cultures, and societies can be impacted by trauma, right? And let me be clear, this is not new. This is not a new thing that is happening, right? What is new is the recognition and the validation of this by bigger systems, right? So let me move on to why it's important to use trauma-informed care. And again, there are other presentations that speak a little bit more extensively about this, but I want to just touch on a couple of things here. One being trauma is incredibly prevalent, right? Many individuals within the healthcare, education, social service settings have trauma histories that impact their behavior and well-being, right? Trauma-informed care improves a client's ability to stay engaged in treatment and supports the reduction of PTSD, depression, and anxiety. Because when people feel like you are trying to understand them and have a compassionate approach to make sense of what's happening for them and help them make sense of that, then it's much easier to trust the system that you are very vulnerably asking for care in. Right? When people feel safe and understood, they are more likely to seek and stay in treatment. And it also helps build stronger relationships between clients and providers. Right? So depending on and we're going to talk more about this, right? But depending on the level of care that you are working in, your training, your experience in using trauma resolution therapies, the client stabilization and self-regulation skills, many other factors, right? Depending on all of these things, we may never know anything about a client's history of trauma. We may never know the details of the trauma story. We may never know the events that happened, right? We may never know these different parts of our clients' lives. And we don't need to, right? We don't need to in order to provide trauma-informed care. Right? Now, for the majority of people working in the healthcare setting, we are genuinely curious about people, right? We all get into these jobs for a variety of reasons, right? This is a huge strength, having genuine interest in another human being. And also, sometimes our own curiosity brings us to a place to want to know the stories of what our clients have been through. Sometimes before our clients are ready to share those stories, right? Sometimes before our clients have the skills that they need to be able to manage the thoughts, the emotions, and the physiological reactions that come with telling their trauma narrative. So this webinar is also about recognizing when asking about a trauma narrative is for our own curiosity and understanding, and when it is beneficial to the client, because sometimes those are two different things. So let's talk about the 4 R's of a trauma-informed approach, right? So firstly, we have realization. Trauma affects many, many people, and it's important to understand how deeply it can impact someone's mental, emotional, and physical well-being, right? If we think about different ways that symptoms present themselves, it might be behaviorally, right? It might be in a chronic pain. It might be in a racing thoughts, right? Recognizing that trauma is widespread helps us create supportive systems that can heal rather than harm those who have experienced it. Recognition, right? So being able to identify signs of trauma in others, being able to recognize when you are bearing witness to a trauma response is incredibly important here, right? When you observe someone having a hard time trusting other people, right? Getting angry or making themselves big because they feel a sense of perceived or real threat, right? Difficulty concentrating, right? Wandering off in session or in a conversation. And understanding that these behaviors may stem from past trauma ensures that we treat people with more compassion and care and are trying to understand the behavior rather than control it or get rid of it. Now, our response. When helping those who have been traumatized, we need to provide services that are respectful, empowering, and supportive. Creating a safe environment where individuals feel in control of their healing process is essential to recovery, right? So are we really listening to what our clients have to say? Are we really observing their actions, their behaviors to try and make sense of what is appropriate and what is not appropriate at different moments in their care. And then lastly, resisting re-traumatization, right? It's important to avoid actions or environments that might unintentionally cause someone to relive their past trauma, right? Now, of course, each of these different pieces, as providers, we are always trying to do our best in, right? Now, I want to talk a little bit about these 6 principles of a trauma-informed approach, but I'm also looking at the time, and I know myself very well, and I know that I will talk and talk and talk and talk and not get to half of my presentation. So I'm going to put this here. I'm not going to go into each and every one of these because I got to make sure I get to everything else, right? But things like safety. Actually, let me ask you all, when you look at this list of trauma-informed principles, can everybody put in the chat which one you find most important? All right, I'm gonna take a sip of water. I know that's a hard question. Wow, there's a lot of safety. Lot of safety. Every single one of these is safety. Depends on the client, collaboration, mutuality. Number 4, number 2, trustworthiness and transparency. Wow. Empowerment. All right. Thank you for that. This is fascinating. Majority of what I'm seeing is that everybody sees safety as the most important principle of a trauma-informed approach. All right, so that is very helpful as I keep talking through this. Right, safety of all involved, right? So safety of the client, safety of their environment, safety of the provider, right? Now, safety is a really wonderful way to go into this next slide, where we are going to talk about the difference between trauma-informed care and trauma resolution therapy, right? Because there are a lot of ways that we hear trauma work. I'm working on my trauma, right? I'm here to talk about my trauma. I'm here to deal with my trauma. Right? How many clients come to us and say, I just saw on TikTok, I just saw on Instagram, I just saw on an article that I have to do this therapy to be cured, to be better, to fix what's wrong with me, right? There are a lot of ways that social media and the access that we have to information is incredibly supportive. And there are a lot of ways that the access of information can sometimes work against us, right? And one of my colleagues is going to be talking about this, I think in July or June for PBHU. So make sure you come to that, right? Because I could go down a whole rabbit hole with that right now. But let me come back to this, right? Trauma-informed care, right, is on different levels of the system, ensuring that we are delivering services, right, delivering care with an understanding of trauma and its impact, right? That understanding lives inside of us, right? We're able to have that eye that looks for it, that recognizes it, that sees it for everybody, right? We don't need to just apply trauma-informed care to clients who we know have experienced trauma, right? This is for everybody. This is for our clients. This is for our teams. This is for the people around us, right? It is compassion, safety, understanding, and care. And something that I spend so much time talking with my clients about is that compassion, sometimes we have this view of compassion of like bubbly and soft, and we're like, oh, it's fine, everything's fine, right? But compassion actually has a sharp edge to it, right? Compassion has a level of clear, direct, honest conversations that are incredibly important in trauma-informed care, right? And we're going to talk more about this when we talk about client-centered care, right? But compassion does not mean just endlessly understanding and agreeing, right? Compassion also means that we are able to be collaborative, clear, direct, and honest with our clients, right? That challenging people, right? And pushing back is also a part of trauma-informed care, right? And this is helpful in healthcare settings, education settings, justice systems, organizations, again, everywhere, right? Now, trauma occurs in chaotic, high-stress environments, both internally and externally, right? When your system, meaning your brain, your nervous system, your emotions, become overwhelmed and lack the resources to process and store experiences properly in real time and afterwards, right? And because of this, healing from trauma cannot be rushed, right? Because trauma is not some thing that we can urgently get through and fix and figure out so that you're okay, right? That's where clients coming in to our sessions, to our treatment, and saying, I need to work on my trauma right now. That's the only way that I'm going to be okay, right? The urgency is the desire to feel relief, right? The urgency is the desire to experience a sense of relief from pain, right? But trauma resolution therapy is not necessarily always the answer, right? Because trauma resolution therapy must be approached with intention, care, and a pace that honors the body's natural ability to reintegrate fragmented information across different parts of the brain, right? So if a client is experiencing acute mental health symptoms or is struggling to manage their substance use, this is not the time to do trauma resolution therapy. This is the time to use a trauma-informed approach to support that client's brain and body in learning different ways of self-soothing. And we will discuss the role of regulation skills in trauma-informed care, right? And this is where language gets funny, right? Because when you are helping somebody learn how to manage the signs and symptoms of trauma, right? Meaning like hypervigilance, a racing heart, a knot in the stomach, feelings of numbness, right? You are treating the effects of trauma without focusing on the trauma story itself. And again, that's an important distinction, right? Because trauma resolution therapy is a specific intervention where we directly support those trauma memories in reintegrating into the brain, right? And in order to do so, that client has to be able to manage and self-soothe and re-regulate all of the different stuff that we run the risk of bringing up while we do trauma resolution therapy, right? I always say this to my clients, especially about something like EMDR. Clients come in and they're like, I want to do EMDR right now. And I'm like, listen, EMDR is about intentionally triggering you. Like that is literally what we are doing here. We are triggering the crap out of you. So you and I both need to know with 100% confidence that whatever comes up when we specifically trigger you here, that your system has what it needs and has the practice that it needs to be able to manage that, right? And that is typically when clients are like, ooh, I don't know if I can, right? I don't know what would happen if that memory came up. I'm kind of struggling to not use substances to cope right now, or I'm kind of struggling to keep myself engaged in my day-to-day work life without isolation, right? And I'm like, all right, those things seem like we need to work on those first, right? So today, we are focusing on trauma-informed care and how we as providers can make sure that trauma-informed care is at the forefront of the ways in which we support our clients and peers and self, to be honest. Right? Now, again, let me say that this training is not a substitute for learning the science behind trauma and the brain and the central nervous system and how they all show up in the world, right? Because understanding the physiological system is really incredibly important to understanding how trauma functions. So now we are going to talk about internal family systems, IFS, right? So let me just start by saying that when I was first introduced to IFS, I was like, what is this woo-woo thing that we are talking about here, right? That I had a skeptical part of me that was like, we'll see, right? And with more training, more supervision, more practice using this, I was like, oh, they've got a point here, right? They have a point in how they conceptualize human beings and the way that we experience the world around us, right? So today we are going to use IFS as a tool to be more trauma informed in our practice, right? Because again, you can have all of the amazing trauma informed policies and practices and be teaching all of the good things to your staff and your clients. But at the end of the day, if we as the people directly engaging with our clients are not implementing it in a trauma-informed way from a personal level, it loses its meaning and its integrity, right? And why would someone not be trauma-informed, right? Typically, when we get triggered or have a part of us take over, or if we were socialized in an environment that tried to use blame and shame as a motivator. So whatever the case may be, the whole idea of this training is not to judge or shame moments when we have stepped outside of trauma-informed care, but to build awareness and intentionality through humility, right? Because we are all complex, flawed human beings. And that is our best tool for being able to connect with our clients, our humanity, right? So as I talk through each of these different slides, please hear me loud and clear that this is not to judge, blame, shame these different parts of ourselves that we have, right? This is to build awareness, right? To build our own humility and our ability to have integrity in our practice. So how many of us have heard our clients describe something using parts language, right? I'm just so anxious all the time. I feels like there's a voice in my head that's constantly saying these things to me, right? This is a common one. One part of me wants to stop drinking, but the other part of me can't let it go, right? There's a part of me that thinks this way. There's another part of me that thinks that way, right? If you have different client quotes going through your brain right now, also feel free to throw those in the chat. I want to hear different ways that we have listened to our clients' experience and been able to recognize that there is an internal conflict happening inside of that person, right? Where one part feels one way, other parts may feel a different way, and you are observing in real time that experience for someone, right? Someone said, part of me thinks it's funny, but the other part is angry about it. Right? That's just not me, or I don't know why I did that. I didn't feel like myself. Another great example, right? When people are experiencing different moments where they look back and they're like, what happened there? Right? I don't think that that was me saying that or doing that, or looking back on my intentions, they don't necessarily align with who I am as a person or how I know my beliefs or my morals to be. One part is sad, the other part is relief, right? Grief. I have a good side that feels one way and a bad side that feels another way. I'm not suicidal, but I don't care if I die today. I know this person is toxic. A part of me wants that chaos and a path to relapse. Yep, in all of these different examples, we are able to sit there and recognize that there is an internal conflict happening inside of that person, right? That there are different parts of them that want different things, that need different things, that are trying to protect us in different ways that they know how. So internal family systems is at the forefront of a movement toward a more collaborative therapeutic approach that relies on clients' intuitive wisdom. IFS offers a clear, non-pathologizing, and empowering view of human cognitive and emotional life and provides a dynamic therapeutic approach. Right? So does anyone hear language or principles of trauma-informed care in here? Right? I also hear relies on clients' intuitive wisdom. I also hear a bit of that client-centered care, a bit of that Carl Rogers effect we're going to talk more about. So internal family systems was developed by someone named Dr. Richard Schwartz, who I am going to call Dick Schwartz throughout this because that's how he addresses himself. That's how I was introduced to him, not personally, but in the world. Right? He evolved this theory over the past 2 decades, and he is trained as a family therapist, shout out family therapists, and has brought concepts and interventions from various family therapy models, such as structural, strategic, narrative, Bowen, to his individual work with clients who were expressing frustration with different behaviors that they couldn't seem to figure out or they couldn't seem to stop doing. Right now, with such a rich background in family systems and how interactional patterns function within the bigger system of a family, of a extended family, of a neighborhood, right, of a culture, Dick Schwartz was able to apply some of these same principles to the different parts his clients would talk with him about, right? How he tells the story of IFS, right? He really talks about listening to the client's experience of addressing some of those different parts, right? He was listening to that experience and starting to make sense of it through the lens of family therapy, through the lens of systems theory, recognizing that when we think about family systems and how all of the different people involved play their own roles, right, have their own feelings, have their own experiences, have their own needs, right, that concept can apply to someone's internal world. Right? So it's really a systemic approach to an individual's internal experience. Right? Now, a few research studies have been done to show IFS as an effective treatment. And now we're talking about it as a psychotherapy approach. Right? So this is classified as an evidence-based practice. But let me just hop up on a small pedestal for a second, right? And say that when we see evidence-based practice, that terminology, right? It's important to actually take some time to go into the research and say, where did we gain evidence about this practice, right? Where was this shown to be effective with what kind of population? Right? Are we talking about in an outpatient setting? Are we talking about in a residential setting? Are we talking about a majority of a certain race? Are we talking about a majority of a certain gender? Right? Because having some of that critical thinking applied to evidence-based practice, right? If you go into the research about IFS, the research is not large, right? There is not a huge research base for IFS as a psychotherapy, right? Which one of the reasons why we are not talking about IFS as a psychotherapy today, but I just wanted to say that, right? Because it is incredibly important that we spend some time thinking about the different practices, the different modalities and treatment styles that we are using, right? Because the most vulnerable, particularly for our clients with trauma, right? The most vulnerable setting is in an inpatient and residential settings, right? And another piece about evidence-based practices is sometimes it can be a bright and shiny way of describing something, but it needs to have fidelity and clinical integrity behind it, right? Are we actually doing what we say we're doing? Is everyone doing it with a level of consistency and standardization in the structure of it? Right, so just some things to consider when taking inventory of the modalities used within your practice or your organization. So another quote from the IFS Institute: IFS is a transformative tool that conceives of every human being as a system of protective and wounded inner parts led by a core self. So we believe the mind is naturally multiple, and that is a good thing. Just like members of a family, inner parts are forced from their valuable states into extreme roles within us. Self is in everyone. It can't be damaged, and it knows how to heal. So, key concepts of IFS. And again, I could get into a whole rabbit hole about this because there's a lot of different parts of IFS, right? But just to keep it focused for the sake of time, I'm going to introduce some of the different concepts little by little here, right? So first off is parts. You've already heard me use part language, right? I've heard from a lot of you that you have also experienced part language with your clients, right? So in IFS, we talk about parts. Now, I know this might sound a bit unfamiliar or a little alarming. Sometimes people start to fear, right, that it could be related to conditions like multiple personality disorder, and we're like, wait, what are we talking about here, right? But IFS is not about having multiple personalities. It's about recognizing that we all have different parts within us, right? It's about understanding that we all contain multitudes, right? So for example, you might have an inner critic, a perfectionist, right? A caretaker, a hurt child, and each of these parts plays a role in shaping your thoughts, your behaviors, and your emotions, right? And these parts develop in response to different life experiences, right? Particularly trauma or difficult emotions, right? So a quick note about parts. Each part can feel as though it is stuck at whatever age it was formed, right? This is where I was like, that sounds a little woo-woo, right? But have you ever encountered a situation where someone, maybe yourself or a client, suddenly acts like they are 12 years old in a certain moment, right? And you're looking at your own behavior or your client's behavior, and you're like, that doesn't quite match how I know you to be otherwise, or that doesn't quite match developmentally how old I understand you to be, or biologically, right? Now, that is likely an active part from that age showing up, reacting to the current situation through the lens of that childhood experience, right? Now, exiles, managers, and firefighters, we put parts into different categories based on the role that it plays, right? Based on how it was formed, based on its job within our system, right? So we'll start with exiles, right? These are the parts that carry pain, shame, fear, or trauma, right? Exiles often get suppressed or hidden, right? If anyone ever have said to you, like, I feel like there's just this part of me that's like locked away in a cage, right? Or this part of me that like I'm not allowed to show, or this part of me that feels so deep that I have a hard time accessing it, right? An exile might sound like the pain that it has experienced, right? So how many of us have heard our clients say, I feel like I'm not good enough. No matter how hard I try, it never feels like I'm enough, right? This might be an exile carrying shame from childhood or from unmet needs or feeling invisible, right? Or I just can't trust anyone. I keep pushing people away before they can hurt me, right? This might be an exile that carries the pain of betrayal or abandonment, right? These exiled parts show you what the actual trauma is, right? Sometimes in a very indirect way. But this is where, as therapists, we sort of read between the lines and make sense of what's happening in the words of our clients. Now, managers work to control everything, right? These are the parts that are like, I'm going to protect you. I'm going to make sure everything is okay. Nothing bad's going to happen on my watch, right? They keep our exiles from surfacing. They keep our exiles down there where they're safe and comfortable, right? Managers work really, 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 really hard to keep us safe. Everything's chill, everything's good, everything's fine, right? So coming from a client, this might sound like, when I leave treatment, I'm just going to stay busy, right? I'm not going to get into anything bad. I'm just going to keep myself busy and I'll be fine, right? So that would be a manager keeping somebody busy to avoid feeling or confronting painful emotions, right? They're managing the situation. Or I just push through. I don't have time to feel anything right now, which might be a manager trying to avoid something, right? By focusing on productivity or staying in work mode, right? Those are our clients who are like, it's 7 o'clock. Why are you still working? Right? Who are like, I'm just so busy with work all of the time, right? That is a very functional manager. Managers often sound rational and well-intentioned, right? But they can create an environment of pressure or emotional suppression to avoid feeling pain that exiles carry. Now, firefighters do the exact opposite. So when the pain of trauma, right, when the exile's pain starts to surface, firefighters literally do what they are described as, right? They hose down the fire. They're like, I can get rid of this real fast. Don't worry, I've got it, right? They respond with impulsive or distracting behaviors, such as substance use, right? Emotional outbursts, right? Big anger, binge eating, right? In an attempt to extinguish the emotional fire, right? So they are there, again, to do the exact opposite of managers, to lose control. So from a client, this might sound like, whenever I get really stressed out, I just eat and eat, and it's the only way I can calm down, right? Or I get so angry so quickly, it's like I don't recognize myself or I don't know how to stop myself, right? Now, how many of us have heard our clients describe a substance as their best friend, right? How many of us have heard someone say, there's a part of me that wants to stop drinking, but alcohol is my best friend, my firefighter, right? That part of me that just wants everything to feel better, that is my best friend, and I can't imagine getting rid of that. I can't imagine living without that, right? People who just shut down, right? People whose parts take over and are like, I'm shutting this whole system down to keep you safe from whatever is happening, right? These parts of our clients and of ourselves serve a really important purpose, right? And we're going to talk more about ambivalence, specifically as it relates to different parts, right? Now, the healing process of IFS, which specifically goes into trauma resolution therapy, is about working with the exiles. That's not what we're going to talk about today, but I just wanted to mention that. Now, all of that being said, right, let it be known that there are no bad parts. So again, as I talk through this presentation to you, I want you to notice what parts come up for you. You could even get a piece of paper, write them down. Do you notice the feeling of being judged? Feeling seen? Do you find yourself getting defensive? Right? Because all of this information is to help you know your own internal system. And the more you know your own internal system, the more effective you can be in supporting your clients and their systems. Now, this is not only the title of IFS creator Dick Schwartz's book, but it is one of the core principles of this model, right? It's the idea that every part in every person, no matter how challenging or seemingly harmful, has a positive intention and plays a role in protecting that person. Now, when I first read this book, I was like, wait. But surely there are parts of people that are pure evil. Like, you cannot convince me that there are no bad parts ever in this world, right? But as you read the book, Dick Schwartz speaks directly to those skeptical parts that show up in the readers, right? So again, in IFS, no part is inherently bad, right? Now, let's give a little bit more of an example of some managers, firefighters, core self. And as I'm talking through this, I want everybody in the chat to just throw in like what you see the most in your clients, right? So again, managers, they are the ones who keep everything under control, right? They're like, don't worry, I got this. I can keep control of everything. They are the people pleasers, right? They are the perfectionists. I do not like the words self-sabotage, just to be clear. That's in here. Don't like the word self-sabotage, right? That is anxiety, right? What is the purpose of anxiety? To keep us safe, right? Anxiety is there to be like, I don't know about that thing. That thing might hurt you, right? Sometimes it sticks around longer than you need it to, right? Overachieving, caretaking, right? A lot of us have a lot of these managers, and we're going to talk specifically about therapist parts. Firefighters, right? They are reactive, they are quick, they get things done, right? This is anger, right? Overspending. How many of us have been on the internet? We're like, I'm going to buy this and buy this and buy this and buy this, right? Video games, right? Binge watching TV, right? And shout out to all of us reality TV people, right? Those are our firefighters, mine at least. Exiles, right? They are our wounded, they are rejected parts, right? In childhood, when somebody is displaying something that is dismissed or rejected by a caretaker or by a protective figure in their life, right? Those parts go underground because they're like, I can see that I am not welcome here. Now, let's talk a bit about the self, right? So when we are talking about systems thinking and working with clients, right? Dick Schwartz, as he was developing this, observed something very intriguing in a lot of his clients, right? He saw that even those who were struggling with severe internal conflict or trauma, there were moments when they spoke or acted from a place of calmness, right? There were moments when you could see through the managers, the firefighters, the exiles, and you could see a level of clarity, right? Now, he has identified this as self, right? Core self, capital S self, right? So when we think about self, we all know that the concept of self was not created or started by this white man in the 80s, right? We can look to many different cultures and philosophies to find the guidance and inspiration for self, right? And how the model conceptualizes self. And for the sake of time, I'm not going to get into all of them because I'm like, geez, we need to take a break, right? But it is family systems theory, right? Buddhism, mindfulness, spiritual traditions, Carl Rogers, humanistic psychology, Carl Jung and his archetypes, right? And I'm just going to go through this next slide and then we're going to take a break. This is what self is all about, right? So when we think about self, it has all of these different characteristics to it. And the way that it is individualized is through the specific human being and all of the parts around it, right? So, and it just happens to work out that everything starts with a C or everything starts with a P, right? So confidence, calmness, right? A deep inner stillness, ability to see things clearly, right? Non-judgmental attitude, thinking about different situations, right? Courage, the willingness to face difficult emotions, right? As I was saying earlier, the part of trauma-informed care where we have direct, challenging conversations is our experience of therapists as being in self, right? We have patience, we have perspective, we have playfulness, right? I'm going to leave this slide up as we take a 5-minute break because I realize I'm already over my time, right? So we will come back. It's 11:13 for me right now. So we will come back at 11:18. Thank you. Thanks, Callie. I am a minute early back, but I have so much to get through, so I'm just going to jump back in. There are a couple questions that I want to answer. I will answer more at the end, but one person was asking about people who identify as multiple or plural, right? So in IFS, when we think about different parts, right, the level of polarization that parts have, the level of internal conflict, the level of extreme roles that parts take on is often how we diagnose people, right? So when someone has gone through different traumatic experiences or has been in situations where they have been forced to take on different roles internally, that causes our parts to take on more extreme roles, right? So a more mild role might be like people pleasing, right? Like a people pleasing manager is, something that might kind of get you into trouble here and there, or you might not love about yourself, but it might not be at a level where it is inherently dangerous, right? Or risky for you, right? Now, a part that takes on the role of a firefighter and let's say like engages in restrictive eating, right? Like that could be a highly polarized, a highly extreme part that can be incredibly dangerous, right? And the more extreme roles that our parts take on, the more that we kind of step into those parts in different situations when we're triggered, right? And to also answer your question, another question, right? Different parts can be present at the same time, right? And that's also where sometimes we get that sense of internal conflict when two parts are showing up and they are arguing with one another as to who is going to keep that person safe in that situation. So from the brain perspective, right, our core self is how we can think about our cortex, right? It has access to all the information. It's big and smart and can critically think about what's going on, right? That is the self. Now, our firefighters and our managers are living more in our limbic system. They are reactive. They are under the impression that we are still in past traumatic memories, and they are trying to keep us safe from whatever was happening within those memories. And then our exiles are farther down in the brain, closer to the brainstem, right? These are the trauma memories that our firefighters and our managers are trying to protect. So the role of skills, right? What do we mean when we say skills, right? These can be called different things in our field: tools, emotion regulation skills, self-soothing. But what we are really talking about here are ways that you can help your client and yourself to get back to self when a part shows up to try and take over the situation, right? It helps to calm the brain and the nervous system, right? It can help us to stay present and recognize that we are in our current present reality rather than in a past traumatic experience. Help us get back into the window of tolerance, right? And differentiate between self and parts. Right? So this is the difference between I am bad, right? That would be a part speaking and saying like, this is me, this is how I identify, versus from self, like I did something I don't feel so great about, right? I'm able to see that part over there that did that or said that or felt that, right? So there's a whole part of IFS about how we can become blended with our parts, right? Which I'm not going to get into that because that's a whole thing, right? But regulation skills help us to access the self, right? Access all of those qualities, all of those beautiful qualities that you just saw on the past couple of slides, right? And all of these different techniques are ways that help us to engage self more and more so that we have greater access to it. So I always like metaphors. And there are a couple different ways that we can illustrate what's happening in IFS, right? One, who has seen the movie Inside Out? Right? This movie models IFS in a really cool way because it shows emotions as parts. And it really demonstrates how, firstly, they all work together, right? They all have their own system, right? Especially in Inside Out 1, when joy and sadness, joy is like, ugh, sadness is pissing me off, right? And sadness is like, I don't know, I'm just trying to be seen, right? And secondly, how one of them can very quickly take over when a situation seems a little bit iffy, right? How many of us saw when anger goes over to that big dashboard and like takes over the controls and is like, don't worry, I'm going to get us out of this situation. That is exactly what a part looks like when something happens and that part is like, I am going to take charge here, right? A less exciting example of this is imagining a conference table where different parts of yourself are sitting, each with their own feelings, perspective, experience, concerns, right? This could be our exiles, our managers, our firefighters, right? Everybody's represented there. The CEO, who sits at the front of the table, is the self, right? This is supposed to be the wise, compassionate, and centered part that has the ability to lead and integrate the various parts of the system to make decisions, right? And the CEO isn't actually a part itself, but it is a calm and clear energy that provides guidance, right? Now, our protective parts are like executives or safety officers who are primarily focused on protecting the individual from emotional harm. And the exiles are the underrepresented voices in the company, right? They have often been pushed aside. They don't really speak up at the table, right? And sometimes when there is like a microphone and everyone is trying to talk at the same time, there's a sense of internal conflict. That's what often looks like being flooded, right? All of your parts are running to try and take over the situation and weigh in on how we should deal with it. So I talked a bit before, I'm not going to spend too much time here on why it is harmful to do too much too soon when it comes to trauma work, right? Like when you are working with an individual, just like a family system, right? For those of us who have worked with families, you know that when you start working with a family, you just take the time to assess who has what role in the system. Because if you start to intervene, if you start to try and get into that system too fast, that family is going to push it out and protect itself in the way that it knows how. Individuals and their internal systems do the same thing, right? So our individual systems will start to have some level of activity when people are trying to get into them too soon, right? So in this, it's incredibly important to have humility, right? First of all, there are no bad parts, right? We all have our own parts that have likely played incredibly important roles that have allowed us to move through our lives in a way that have brought us here to this webinar today, right? We have so much curiosity and compassion about our parts, and that allows us to understand our own internal system, right? So humility is the quality of having a modest view of our own importance, recognizing both strengths and weaknesses, and it involves being open to learning and acknowledging that there is always more to understand or improve, right? It involves showing respect for others' perspectives and contributions. And it's not about diminishing yourself, right? But about having a balanced self-awareness that is grounded in reality. So as we talk through, we're going to move into the integration part. I'm like 27 minutes late to this. We're going to move into the integration part. And as I talk through some of these different things, I want everyone to notice the different parts that show up for yourself, right? Notice what you are experiencing. Notice your own parts that have a say in how you are experiencing this webinar today. Right, so the goal here is to allow us to get back into self and to have more access to self. So again, we are not villainizing or shaming parts here. We are asking for humility to have increased awareness about them. So again, this is the part where we're going to talk about interpersonal, right? So different conversations with clients, treatment team, colleagues, etc. So let's talk about client-centered care. So this concept was influenced by the work of Carl Rogers in like mid-20th century. And person-centered care is really advocated that clients be at the center of the therapeutic process, right? And he believed that people have the capacity for self-directed growth, right? Particularly when they are in an environment that is empathetic. So I imagine many of us have heard the expression unconditional positive regard, right? This is some of the root of trauma-informed care. It doesn't mean that you always like or are happy about or never get triggered yourself by client behaviors, but it does mean that you have your own tools to be able to pause, recognize that your own stuff is coming into play, and re-regulate before adding a narrative or response to what's happening in front of you, right? So I was going to talk about the whole history of client-centered care, but let's just start by breaking down what this really looks like in action in behavioral health. Now, client-centered care is about believing that our clients are inherently good and that all of their behaviors that might suggest otherwise serve a protective purpose, are learned over time, and tell us they don't know a better way of responding in that moment. Right? So it means that we have an understanding that our clients are possess an innate ability to grow and develop if they are in an environment that supports that. hence the webinars that my colleagues have done about outlining trauma-informed practices for a therapeutic environment. Now, client-centered care does not necessarily mean always doing what the client asks for or wants in the moment, but what is in the best interest of the client, right? Now, how many of us have heard a client come to us in the hallway or walk into session and announce, I'm going to stop my medication because I am actually feeling way better, or I'm scared to call my wife because of the hurt I have caused her in my active addiction. Or after treatment, I just need to get back to work because I learned all that I need to know here and I'm stressed about money and a few weeks of treatment should be just fine. Right? But I don't know about you, but all of these raise a very big red flag for me. And these are very vulnerable positions our clients often get into when a part takes over and they stop consulting with their cortex, aka self. Right? Now, would we go ahead and say, yeah, totally, sounds like you don't need your meds anymore? Or, yeah, keep avoiding your wife, that's going to work out great. Or 100% urgently go back to work where the stress of daily life had a profound impact on your mental health just 3 weeks ago? No, right? In those moments, client-centered care is about recognizing in your own self what is happening in front of you, right? Seeing that a part of that client who is ultimately trying to protect them, right, but doesn't have all of the information, is trying to make a sound decision and is, driving the bus at that point. Now, this is where our jobs are to actually have some potentially difficult conversations, right? To first pull off of that statement and help the client to access self through regulation, right? If somebody is operating from a part, then we can help them move back to self with a regulation skill that we do in real time together, right? Can we pause to do some breathing together, right? I hear what you're saying. Is it all right if we go take a walk and get some water before we talk more about that, right? Actively supporting that client in a collaborative way and getting back into their self energy before we start down that road, right? We're not getting into a tug of war with that part there, right? This is a lot of motivational interviewing as well, right? We are not trying to go into that statement. We are trying to help re-regulate and recenter that client before we keep engaging about this conversation, right? So there's a lot more about client-centered care, right? But a huge takeaway from this slide specifically is when you recognize a part is showing up in a client, firstly, also recognize what shows up in you, right? I have a strong convincing part, right? When I hear a client say something that I'm like, ooh, that is not going to be good, I have my own part that shows up and is like, you got to convince them to do the other thing that they're saying they don't want to do, right? And where does that land me? Nowhere good ever, right? But when that part shows up, I'm like, yep, I hear you, I got this, right? And that part can pause and I bring myself back to, whew, okay, let's re-regulate together and then let's start talking about this, right? Slowing the conversation down, right? Let's talk about ambivalence, right? Something that historically in our field is not loved, right? Or we just continue to throw motivational interviewing at it, right? And the concept of ambivalence is something that has really evolved over time, right? When we think about in the world of AA, in the world of 12 steps, right? Which, don't get me wrong, I love and appreciate 12 steps in the AA, right? And there was a huge narrative around ambivalence that is like the client is resistant to change, the client isn't committed, the client isn't blah, 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 right? But if we think about this from a parts perspective, if we think about ambivalence through the lens of IFS, right, we can understand more and more that ambivalence might actually be coming from somewhere and serving a purpose for that person. It might be past trauma, fear of failure, lack of trust, right? And again, I don't love the words self-sabotage because no one is intentionally sabotaging themselves, right? Their parts are trying to guide them back to ways that they know how to operate and stay safe, right? That's different than self-sabotaging. That's familiarity, right? And parts that say, listen, I have handled this before and I've gotten you out of it every time, right? Done some other damage, but I know how to work with this. Right, so IFS would say that this is really an interaction between different parts of the self that hold conflicting desires, beliefs, or emotions about a situation. Right, this is where so many of us hear, a part of me wants to stop self-harming, and a part of me doesn't know how. Right, or a part of me wants to stop using, but another part is scared. Because a protective part may want to keep the person from taking a certain risk, like going into treatment, starting therapy, or quitting a harmful behavior, while a vulnerable part may be looking for healing or change, right? And these two parts may be pulling in different directions. So ambivalence is our experience of seeing a client with two different parts going in different directions, right? And ambivalence can be a manager and a firefighter. It can be an exile and a manager. It can be any number of parts, right? It can be like 5 in the same time, right? I've talked with some clients that are like, I got like 7 parts going right now and that I'm feeling all types of confused, right? But the real message here is our ability to recognize when that's happening and be able to slow it down and re-regulate, right? So again, with direct client interactions, I'm going to talk more about this in the next slide, right? But it's being able to recognize, regulate, and then reinforce the experience of being in self before returning to that conversation. Right. And this is where there is such an important consideration for the different levels of care, right? Because when we recognize that clients are coming in at a higher level of care, they are so oriented towards their pain. They're so oriented towards their parts and really operating from their parts. And they're so acutely aware of what feels scary, bad, hard, painful, right? Because they are trying to keep themselves safe. And those parts have taken on such extreme roles that that is how they know themselves to be in that moment a lot of the time. Right? So how many of us have ever asked a client, how are you today? And their answer is awful, everything's going wrong, nothing's good, terrible. Even though you just learned about something positive that had happened. You're like, I don't know if that's really what's happening, right? But that tells you they're not able to see it because they're still in that part, right? So again, re-regulate back to self and then highlight that, right? Because if somebody is still in the, nope, this is awful, nothing's going right, I'm not okay, and you're like, but what about this thing? Then the part's like, you're not listening to me, right? So we can validate without following the yellow brick road of, well, what's so awful that's happening? What's terrible, right? Going into that part and having a conversation with that part, right? So in inpatient residential, this is about finding self and highlighting moments of self, right? So remember all of the C's and all of the P's, and you'll get the slides that have that information on it. And being able to say, like, hey, I saw a little bit of curiosity there. I saw a little bit of creativity. Let's go into that, right? Let's open up opportunities for that client to act from their self. And in somewhere like PHP, where we're starting to see a client stabilize and practice their skills, right? And re-regulate, meaning going from part to self to part to self, right? We are expanding their sense of self, expanding their experience of being regulated, having all of the information to make decisions, right? And building up someone's protective factors and recovery-oriented activities offers the self more and more opportunities to be present. Now, in somewhere like IOP, we are in the practice of maintaining, right? Maintaining the experience of living in self, operating from self, right? We are hoping to sustain wellness, health, relationships, and it doesn't mean that you're not going to get triggered, but it means that you have enough access to self that you're pretty quickly able to come back to it. Now, general outpatient, right? This is where you have the opportunity, should your client decide to do some of that trauma resolution work, right? Because if this person is appropriate for 1 hour, once a week therapy, that tells me that they are able to sustain access to self outside of that session, right? And that gives us the opportunity to focus on the exiles if they choose. But let me be clear that people do not have to do trauma resolution therapy in order to live a meaningful and sustainable life of recovery, right? They can choose to, but it's not necessary. So I want to talk a little bit about one of the core principles of trauma-informed care, right? Because our parts develop in the context of the world that we live in, right? And the world treats different people differently, right? Sends direct and indirect messages to human beings about their safety, right? So individuals with marginalized identities, which let me pause and define this as a social identity that experiences discrimination, exclusion, or oppression, right? And these identities can be based on many different factors. This is not an exhaustive list of that, right? Such as race, gender, sexual orientation, disability, socioeconomic status, right? Our parts are formed while assessing for safety and trying to figure out what is safe and unsafe. So individuals and groups can develop different parts that are incredibly perceptive of threat, danger, and exclusion that is based on their identity or multiple identities, right? So it is incredibly important to understand the context in which your client lives, right? And the bigger systems in which their parts are formed. Because when we start to see different parts that are trying to keep them safe on the basis of their identity, right, then we need to be able to validate that and see that part so that it feels safe. Now, I think about the language of illness and the language of recovery as different ways that we can hear if we are in a part or we are in self, right? Because if I am in a part, if I am in a manager or an exile, if I'm in a part of myself, right, then I am going to say things and do things that might not align with my understanding of trauma-informed care, right? How many of us have started talking about a patient in a way that we're like, ooh, let me walk that one back, right? Let me try to say that a different way. Because sometimes our parts and our emotions and our own experience of being triggered can take over, right? And again, that's not a bad thing. The important part is that we're able to recognize it and hear it when it happens and shift our language in a way that more accurately and compassionately describes what's happening, right? So when we think about how we talk about our clients with our colleagues, how we talk about our clients with their families, right? With our friends and family when we come home for work, right? It's incredibly important that you pay attention to how you are describing something because that tells you what's happening in your internal system and gives you more information about how to care for it. So again, coming home from work, we've all had those moments, right? Where the clients were so annoying today, or no, X, Y, and Z is happening. And we're like, pause. Let me rephrase that. Let me think about what is going on from self. Let me re-regulate so that I can more accurately describe what just happened today. Right? Because sometimes we say things out of frustration that we later look back on and we're like, ooh, I did not mean that. Right? That was one of my parts that was triggered, that was saying all this crap about that. So, from an individual level, right, I want to talk through some common therapist parts, right? And I'm going to credit this slide. I adapted this from a previous supervisor and mentor, Eric Fox, who is a wonderful IFS therapist, right? And has taught me a lot about my own common therapist parts, right? And this is where our humility comes in. Can we be humble enough to recognize our own stuff? Right? And as I'm walking through each of these, I want you to be aware of what's happening in your own internal system. So, approval seeking managers, right? The experience of, I want to be liked by this client so bad that I'm not going to challenge some of these things that they're saying, right? I want to be liked, so I'm going to pretend I didn't notice that, or I'm going to let that thing slide, or I'm going to move my own boundary. Right? Caregiving managers, I'm not going to go through every single one, right? But caregiving managers, right? Racking our brains, staying up all night, worrying about what is going to happen if we don't caregive our clients, right? To the point where it gets in the way of our ability to live our day-to-day lives, and it gets in the way of our clients being able to be empowered to care for themselves, right? Our evaluating parts, right? That really sit in the theoretical, right? They're like, I can conceptualize this, I can look at this from the bigger picture, because if I can logically make sense of something, then I can handle it. In this way, our logic is trying to control the situation. And then the savior parts, right? Believing that I know better about your life than you do. Right? Believing that I need to rescue my clients from the reality of their own lives. Right? If you feel comfortable, go ahead and throw in the chat which one you relate to the most out of all of these. Right? Because there are so many more different types of parts that we as therapists come into this field with or develop within our experience working here. Right? I'm seeing a lot of evaluating parts, approval, caregiver, cheerleader, savior, right? And let this be an experience of just normalizing, right? That as human beings, we have our own whole entire internal system. And again, that is not a bad thing. It is good, right? Because the more aware we are of some of these different parts and when they show up and what purpose they serve, we're able to show our humanity and model the experience of going in and out from a part to self, right? Because we are not ChatGPT, we are not robots doing this job. We are human beings making a very human connection with our clients. And that is what is so valuable about this work, right? And the more awareness, the more insight we have into how exactly that plays out, the more opportunity for connection and effectiveness we have. Right? So I hear a lot of evaluating, approval seeking, right? Those parts give us information about ourselves, and they give us information about our own needs, right? So they're actually incredibly valuable. So if you find yourself jumping to conclusions, judgments, answers, acting urgently, speaking from your own parts, immediately trying to make sense of what's happening or draw conclusions, right? Let's talk through some tools for coming back to self, right? Firstly, slowness. Well, I'm jumping to my next slide. Here we go. Slowness is the best friend of trauma-informed care, right? Putting at least one skill in between the situation and your brain's response, right? Allowing yourself the opportunity to come back to self is the best way that we can provide trauma-informed care, right? Is the best way that we are able to care for ourselves and our own system and care for our clients and their systems, right? So taking a deep breath before you let your brain go on a whole narrative about what's going on, feeling your feet on the ground, right? And a lot of times people think that talked to a lot of people who say, well, I don't really know how to use skills, or I don't know what skills really look like in action. And I think a lot of times we overcomplicate it. Skills are ways of self-soothing. Skills are very simple, right? Am I in self right now? For me, I know that my convincing part is way more prominent with some of my clients than others, right? So going into some of those sessions with my clients where I know my convincing part is going to be in a seat right next to me, waiting to be used, right? Then I need to be in active conversation, like, hold on, I see you, I hear you, I got this. Right? Get to know your parts and get to know which ones come up more often in different situations, right? What types of behaviors or words or emotions that you observe in other people that bring up different parts of yourself, right? Taking a step back and imagining yourself in an observer seat within yourself and watching the conversation from a different perspective. Right? Because when our parts get activated, suddenly we're in like a part battle with our clients sometimes, right? Our clients are like playing tug of war because our parts are like trying to run the show and so are theirs, right? So the whole message here is to allow ourselves the opportunity to expand our experience of self and to be able to operate from self and get from our parts back into self as often as we can, right? Because this is where, when we think about the principles of trauma-informed care, when we think about unconditional positive regard, right? It's giving the clients the opportunity to grow, heal, be in recovery in an environment that supports it. Right? And we are that environment, and our self energy is that environment. So I want to end with one example that a dear friend and colleague of mine, who is a wonderful IFS therapist, Amy, told me of this practice that she does before session that helps her get back to self, that I want to share with you, that she gave me permission to share with all of you. So she closes her eyes before session and imagines these little sailboats at a harbor, right? This is very sweet. And those are all her little parts. And before session, she helps them and encourages them to sail off so that her harbor is not as crowded so that she can be more clear in how she sits with her clients, right? And the boats will come back when the time is right after session, right? So I thought that was a very sweet and lovely way of thinking about it. And there are many different ways that as therapists, we can notice when you embody the 8 C's, right? So think about inside session or outside session, when you're talking with colleagues, when you're talking with friends, when you're out in the world, right? Think about a time when you felt really confident and clear, right? When you feel really strong, ask yourself, what am I experiencing right now? Am I in self, right? Am I using my creativity? Am I using my courage, my clarity, my curiosity, right? Because that allows us to expand on our experience of self, right? And I know that everybody sitting here wants to be the best version of their self for their clients, for themselves, for their families, for their friends. And the message of today is everything that you're doing right now, right? Even by attending this webinar, by listening to me talk for the past 2 hours, right? Identify the moments where you are already doing so, where you see these characteristics in how you have been operating. So I'm going to take a few minutes to answer some questions. I have a whole bunch of resources, right? So I will look in the Q&A over here. Now, just to go through a couple of them, if you prefer to read, these are, and again, you will have access to all of these slides, so don't feel like you need to like aggressively type them down. If you read, these are some different book recommendations that I have that give a lot of insight into trauma-informed care, this one specifically about IFS. And then if you read, and you like to go through big, lengthy documents that have a lot of beautiful information, there is a bunch of information out there from SAMHSA, from some of our different sites that helps you understand how to implement trauma-informed care. If you like to watch, right? If you like to watch some YouTube videos, here are some different videos that I recommend, right? One is Dick Schwartz explaining IFS. One is Dr. Nadine Burke-Harris, who was pivotal in the ACEs study, describing physical health and later life outcomes. And if you like to listen, then there is a podcast episode where Dick Schwartz actually does an IFS session with a couple of people who host this podcast, right? I imagine some of you are familiar with We Can Do Hard Things. And then this is an IFS podcast that was recommended to me that I have not yet listened to, so I have not vetted it, but, and then next month, we have the wonderful Michael Fanjoy talking about a really exciting topic. I'm very excited for this one. So let me look at these questions here. I have a client who uses ChatGPT to give her feedback on certain feelings. It seems to help her, but ChatGPT isn't her therapist. I am. Thoughts on what to say to her. It doesn't seem to be harming her. That is so common, right? I'm working with a 15-year-old right now, and I'm like, tell me about your relationship with ChatGPT, right? So firstly, let me say that in June or July, Callie will keep me honest about this. One of my amazing colleagues, Wendy Elliott, will be doing an entire webinar on the internet as a pseudotherapist, right, and social media and therapy. So she will talk extensively about this. What I would say is I would actually ask her to like go through that process in session with you so that you can help her like develop some critical thinking around that. that would be my encouragement, right? Is like, I want to see actually in real time what this looks like for you. And I want to be able to support you in like making sense if this information is supportive in a certain way or like what part it's speaking to. Um, that's what I would say. We don't really have many other questions. And Callie just gave a link to the June webinar with Wendy. So thank you, Callie.
You're welcome. Yeah, I think you answered everyone's questions as they were coming in. So, oh, someone did ask about the PESI training. Maybe is there more than one? Are you
There
just
is. I'll include the link in the resources to the specific one that I was talking about.
Okay, great. We'll make sure we have all that. And I'll put everything in the training in your attendee dashboard early next week. So there's a lot that I want to make sure I'm linking with the books. I'll get all the links for you. So when you get the email after this with your evaluation link, you'll see an option to view your attendee dashboard, and that's where you'll see the resources and your past trainings. So that is where you'll see those information. And then next month, I hope I'll see you all again. April 25th, the Gut Brain Connection with Michael Fanjoy. You can register for that in our portal. Okay, thank you all. Have a great weekend. Thanks, Gwen.
Thank you.